Welcome to the Paradigm Concept. Today we're in Denver, Colorado for an exciting collaboration between Paradigm Oral Health and the Mayo Clinic in something that we're calling Paradigm Innovation Institute, or PI2. PI2 is a center where we will be innovating, doing novel research, and really redefining the future of our specialty and focusing on oral health as not just a clinical matter, but a part of overall health. And to talk about this, I couldn't be more excited or luckier to have Dr. Kyle Ettinger with us today, who is an oral and maxillofacial surgeon at the Mayo Clinic and a leader in head and neck oncologic surgery. So Kyle, I'm excited to talk today about some of the innovations, some of the areas you're focused in, and learn a bit more about you and sort of see if we can come up with some ideas for where this can all go in the future. So first off, I'd like to, obviously I know we've known each other for a long time, but just for the audience, I'd love to know a bit about your background.
Yeah, well, certainly appreciate you having me on, and obviously a very kind of poignant and interesting kind of breadth of topics that we'll be going over today. So my original background, I'm originally from the Pacific Northwest. I grew up out in Washington State, outside of Seattle. Did a lot of my kind of dental training, undergraduate training in Washington. Came to Mayo Clinic in Rochester for residency training. Subsequently went on to do my head and neck oncology and micro fellowship at the University of Florida, Jacksonville. Was a Mayo Scholar during the year when I was away in Jacksonville, and with plans to come back on staff at Mayo Clinic, and I've been there ever since.
Nice, and I think it's kind of interesting. You have a twin brother, right? And kind of the path that you two have taken is like stranger than fiction almost, or not stranger, but like super ironic.
Yeah, correct. Yeah, so I am an identical twin. My twin brother, Russell Ettinger, is a craniofacial trained plastic surgeon. Did some of his, again, training at University of Washington as well. Did his residency in Michigan, and then back to fellowship in Seattle. And we tend to intersect at very interesting points in life, and people that we've known independent of each other in our own professional spheres that we'll commingle with in various locations and conferences. And yeah, it's not uncommon that we get kind of confused for one another, and he ironically has a lot of interest in things that we maybe think more traditionally or born from oral and maxillofacial surgery as a specialty, and with my focus on oncology and microvascular reconstruction, that's something that was largely born out of that specialty in plastics as well as orthopedics. And so we kind of I guess have kind of picked opposite specialties for what we to some extent do as a large component of our practices.
Yeah, I believe I've seen his name on publications and our specialty and things, which is super cool. And but like how did that? He kind of went into hard tissue surgery, and you sort of went into soft tissue surgery, which is a bit backwards for both of those specialties at their core. Like, did you guys always know that's what you wanted to do, or how did this all evolve?
I think most of us in kind of deciding what we ultimately want to do are kind of just jumping in the river and just start swimming with the current, and so things will kind of tend to evolve, naturally. But I think in some of the context for his background is like some of the stuff that's intriguing is maybe the stuff that you get less exposure to, or the things that seem kind of new, novel, and interesting. And I think that probably spurned on a little bit. And our professional development is as far as twins go. We spent most of our lives kind of together, even all the way through kind of undergraduate, and then kind of had a separation in terms of like physical separation in terms of co-locating around the time of when I did my dental school and he went to medical school. And so a lot of our professional development was done effectively independent of one another, but it's just always interesting to see how much is the nature versus nurture are the things that we kind of gravitated towards. And we've even subsequently found that just in discussions when I go on trips with him and we kind of talk, that we share a lot of the same idiosyncrasies and kind of personality traits, even in like an OR setting, which was something that was completely developed independent of one another. And he's even had trainees that have mentioned that we've kind of mutually worked with in different settings say that, oh, you guys are almost the same person, kind of a thing. So I don't know if yeah,
it's super interesting. And there's probably just some intrinsic competition between like plastic surgery and oral maxillofacial surgery and things. So is there like any does that show through in sibling rivalry at all, or is it sort of more of a collaborative?
No, I think it's largely collaborative. We'll still give it to each other about certain things, just as more as wearing the hats of siblings than anything professional. I do give him flack for publishing so much in the OMS literature when in reality I think sometimes he maybe forgets what specialty he's in. But it's ironic just because we spend so much time together growing up that actually the time that we do get to spend together now is is something that I think probably look forward to more, because we were always historically very competitive, as I think most people, intrinsically are in certain professions. You have a very specific kind of competitive nature that helps you through life. And when you're a twin, it's a competition and a comparison that's constantly always in your face, because you can't escape it, because you literally have somebody, interested or doing similar things, and whether that's through sports, academics, what have you. But I definitely think that certainly shaped who we are personally and professionally.
Yeah. I mean, it's ironic that you guys both went into very similar surgical specialties, but then also like your career paths both have sort of reached the pinnacle of academics and things. So is that something you or both of you kind of always had in mind, or like what kind of drove you to go down that path?
Yeah, no, I think we definitely, I don't know if there's like a specific gene that people have of, they take pride or interested or motivated towards kind of, the path that's more challenging. I think about it as like in the context of like marathon runners, right? Because, marathons are largely towards the end of it, a lot of pain and anguish and struggle, and yet you finish it and you can't wait to do the next one. And so I think for, both he and I, he chose the craniofacial route, which is a very challenging route to go in terms of the actual percentage of people that go on to practice that in their actual practice in the field of plastic surgery or OMS or ENT or any of the various routes to get there. But I think there's also personal reward in doing something that's challenging, or doing something that requires a lot of input, and it requires a lot of pride, and it requires a lot of passion to do. And I think we both probably to some extent are motivated by that as well.
Yeah.
And so we don't do things always because they're easy. We do it because it's a challenge and it's hard, and that's you get more reward from that, I think, in general.
When you went into residency, did you know that this is the path you'd go down to towards head and neck surgery?
I don't think so. I mean, like, not maybe initially. I mean, it was definitely something that I was interested in a lot of the kind of pre-residency, formative years, or experiences that you do. Obviously, there's, I'm sure, listeners that haven't been through kind of the OMS track, but obviously you spend a lot of time pre-application and residency doing externships where you get exposure to various programs and the types of things that you actually ultimately end up doing in kind of the field of maxillofacial surgery. And, a lot of the places that I found interesting were the ones that had, head, neck, and microvascular capabilities, and it was intriguing, but I wouldn't say that I went into residency, some people, come in out of the womb knowing exactly what they want to do, and that was certainly not me. That's definitely something that grew over time. I was very fortunate at Mayo to have two phenomenal chiefs, and they even kind of alluded to, as kind of the year went on, like, oh, when you do your so I don't know, I think I was necessarily putting out the vibe per se, but I think maybe they saw that in me as an area of interest. And like I said, I wasn't stating that outright or screaming that from the rooftops, but it definitely was something that I think I'm, in terms of my own kind of mindset and skill set, well suited to, and that's why I love doing it.
Yeah, I've been fortunate to get to talk with a number of people that have sort of reached the pinnacle of what they do, and I'm always interested in like what's the kind of the mindset, what drove someone to get there, like what's that thought process, how does it evolve, what's the course, because I think it's super helpful to learn and sort of adopt some of those ways of thinking. And I just think, for a lot of people that listen to this, especially residents, I think that's really important. And, we were talking last night at dinner about kind of like goalless thinking. For me, it's always about like, I love building things. I love thinking that we can still do something better, and, an abundance kind of mindset. That's just sort of like how, I don't know if it's right or wrong, but that's sort of how I think what's driven me over the years. And I think what you've accomplished, to do, the most advanced head and neck surgery is, remarkable in our specialty, because there are some obstacles amongst other specialists and things, but then to do it at, probably the greatest institution in the history of, healthcare. And I think everyone that knows you, or at least as I know it, would say you're like maniacal about perfection. Like and so what is it that's like created that?
Well, so I think first and foremost, I would be remiss if I didn't acknowledge the people that helped me along the way, and the mentorship that I received, getting the opportunity to be kind of mentored under, for instance, Kevin Arce, who's my current partner in practice, and he was one of the first individuals within the oral maxillofacial realm at Mayo Clinic doing this type of surgery, and I was extremely fortunate to be able to train under him, to work with him, and now get to practice with him as a partner and colleague. And so for those that know him, he's like the easiest going kind of guy, which isn't necessarily the archetype for somebody that's in the head and neck space. I think there's a certain kind of personality and connotation that goes along with that over time, and he's always been somebody that's been able to make it, a fun, relaxed environment. And he certainly, fostered and guided that along the way for sure. And, we're all standing on the shoulders of those that came before us. And I don't certainly think that anything that has come to pass or will come to pass in my career is without those that, training, my fellowship training with Dr. Fernandez. I mean, like, there's countless individuals that have, contributed to the development of the individual. And so, don't get me wrong, there are definitely some, in terms of the perfection thing or the constant drive to strive for perfection is something that I think to some extent you're born with to a degree. It's an intrinsic quality I think that some people have, and it's a strength, and it can also be a weakness in certain respects. But yeah, I think it's just something that, like, even just relative to my brother, he's very similar. And so it's hard to say whether that was cultivated or just, inborn, but it's something that like I said, definitely plays out well in the type of work that we do. And these are surgeries many times that, patients are entrusting you with a lot, right? These are, fairly significant surgeries and, real potential for, outcomes if not done well. And even when done well can sometimes still have, outcomes that are less than desirable. And so I think we owe it to our patients to go into work every single day expecting perfection, right? If it was, my family members, I wouldn't want anything less. I tell the residents that, as surgeons, we're not allowed to have a bad day.
I love that. So how do you think about, when you're doing, a fibula or something, like what's your mindset? Are you sort of at a point where it's a process for you and you are going to like follow the process perfectly every time? Or are there things technical skills you're trying to improve on or changing your process, or like where are you at in, that point in your career?
I don't think that we ever kind of fully kind of attain perfection, right? I think, and whether this is just an outlook, but I think that it's not attainable per se to feel like, oh, I did that one perfect, right? I think invariably, and even whether it was through sports growing up, it was always an intention to like, okay, this went fine, but like what didn't go well, right? Like we within our kind of oncology team, our clinical team, there's patients that, we'll treat and they don't have any issues and they do great. And those are the ones that are sometimes you're like, it's almost hard to remember. Whereas there's ones that have issues or there's something that occurs, and those are the ones you'll never forget, right? Those are the ones that are kind of seared into your mind. When I am doing a surgery, and my residents know we take a lot of photos. That's a curse from Dr. Fernandez. He likes a lot of clinical photography and OR photography, and it's great actually for re-looking back and essentially getting a literal and figurative snapshot of what you're doing. And I use those to actually look at like, well, did I like how this was done? Because there's always opportunity for improvement, even if you think, and I would argue if you think you've done it perfect, then you're probably at the point where you maybe shouldn't be practicing as much, because you just can't attain that. For our patients, they owe it to try to always continually get better.
I know you're a pretty exceptional golfer. How do you think about golf and surgery?
There's probably some things that go hand in hand. I'm, according to my wife, allowed one hobby. And so my selected hobby is golf. I'm not allowed any more than that. But I think there's a lot of interesting parallels. Sometimes I think about it, and again, I think you're overblowing the golfing ability a little bit. But, it's like sometimes you're lining up a 3-footer and you're like, this should be easy. It's like you're just doing, a really challenging case under the microscope, like, earlier in the day. And now we're like stressing out over like a 3-foot putt that maybe means almost nothing in comparison to what we do. But it's just the differences in environment. And I think about it more as kind of an opportunity in some extent to kind of get away from the day-to-day and kind of the stress that goes along with the profession and the types of surgery that we do, because what other hobby can you just go out and recreate for 4 hours outdoors and enjoy an arena that's so different than what you and I do day after day.
I mean, to me it seems like a sport. I certainly haven't mastered it, but it's to me seems similar to surgery in that it's like very precise. What groove are you hitting the ball on? What's your spin rate? Like just very small things make an enormous difference. Like in surgery, I imagine that probably attracts you to it a little bit. Yeah,
it's a repetition of skills, and it's something that you don't get me wrong, there are definitely those that have an innate ability that they're born with, but generally for most of us, that's not something that necessarily comes naturally. And it's something just like in surgical training, you have to put the time in to earn. And we all come with the hand of cards that we're dealt, and for some people that's easier, other times it takes more reps. And so that's definitely something that I have come to enjoy over time. And even getting into more kind of like quote unquote competitive golf is something that I also find super interesting and have done a little bit more with, because again, it's kind of that replication of stress, putting yourself in an uncomfortable environment and seeing what you can do.
Yeah.
Which has a lot of parallels to surgery.
Yeah, absolutely. It's like kind of like the harder you work, the luckier you get kind of
right
in surgery and,
right.
and on the golf course.
That's right.
That's great. So, tell me about Mayo Clinic. What has that meant to you? How has that been a part of your, career path?
So Mayo Clinic, not that we need to kind of delve back too far, but my journey with Mayo Clinic started in 2011. And in the process of kind of, thinking about where, in terms of looking at starting residency, where we'd want to go. And I was actually very fortunate to, by happenstance, get paired up with Dr. Guillermo Chacon, who was kind of coming out of academic practice at the time, but transitioned back to the University of Washington in Seattle. And so he was kind of doing, I won't call it like an outreach thing, but basically he was kind of an adjunct professor. And so he actually at the time helped me to kind of go through the book. We had a book at that time that kind of gave a synopsis of all the different programs. And he went through and starred the ones, being that he was an academician and knew well kind of what the ecosystem was, and helped me to kind of select out which programs, because you can't visit them all, it's impossible. And one of the ones that he starred was Mayo Clinic. And so, being that we were from the Northwest, I'd been, recently married, and my wife and I kind of thought that we'd be sticking around in the Northwest, just given our family ties and everything close. And it was on the interview trail. And then when you go on interviews, and I'm sure a lot of the listeners would relate to this, you get a sense and a feeling of what a place is all about and the culture, because it's palpable. You can tell. Like, people can try to like sugarcoat it in one way or another, but you can tell like what it's like, what the residents are like, and what the setting is like. And I remember distinctly coming to Mayo, and again, I didn't extern there. I came in with very little knowledge of kind of, again, on the coast, we don't tend to know of Mayo as well as, say, in the Midwest or the central part of the U.S. with very limited information. And like I said, I had to basically, post-interview, call and talk to my wife and say, hey, listen, I think things may have changed a little bit in terms of, I just felt that it was a really unique mix of culture that I felt was very different and very palpably different than a lot of other places I had been to, and well suited to my personality. And like I said, it's just an environment that is very unique in, like I said, the large scale healthcare ecosystem.
To me, I was just like such an amazing opportunity to go there, like just an absolute blessing. And growing up in Nebraska, it was it's close, it's sort of revered as like the as it is around the world, but especially being close, I was always just like, it was unfathomable to be able to go there. And I remember interviewing, and it was like, my number 1, 2, 3, and 4. Like, if I didn't get in there, like, I don't know what I would have done, like change professions or something. I really wanted to go there so badly. But I can remember, and I was like on pins and needles. We had just gotten married, and we had like an answering machine, like an old school answering machine. It was 2003 or 2004, and I missed this phone call. I was gone, and it was Dr. Jim Van Ness. And, it was like a couple of days before the match was due or something. And he was like calling to see if I had any questions or something. And I was like, oh my gosh, I think maybe I might actually get in. And I saved that answering machine, came across it the other day. It's like, I can't ever throw this away. This is like, sort of a piece of history in my life. But I thought it was just, like you said, talked about going on the interview there. It was just so much different than anywhere else. And of course, there's tremendous places to train. Not that we trained at a place any better than anyone else, but it's just being there. It's just the sort of like the gravity of like, oh my gosh, there's generations of people and that have committed their life to here, and that if you're not on top of your game, and even like the attire, everybody wearing a suit, it's just like a level of discipline that I think is just kind of second to none in my experience. I love that idea of discipline, like doing the things that you should do when no one's looking, just because it's the right thing to do. Going in and seeing the patient at 3 a.m. because that Will or Charlie Mayo did that 100 years ago or something. And I can remember so many scenarios like that there. I don't know, what are your thoughts on those?
Yeah, absolutely. I mean, I also distinctly remember, for me, maybe it was, potentially a little bit kind of later, but I distinctly remember, being there on kind of like my first day when you're kind of just trying to get your bearings and getting kind of checked in. And I remember walking into what is now the entrance with the new hospital building. Everything else is closed currently, but walking in my suit, I'm sure I had to get like my quarterly photograph and all these other things, and like literally feeling like the weight of the institution, like literally and figuratively just like hitting me at once, being like, this is kind of crazy. Like, you're here. I don't know whether it was like an imposter syndrome or kind of what it was, but then just coming to that realization, like walking in, with the, grand, hallway between, and realizing like, yeah, this is real now. So
yeah.
Time to get going, kind of a thing. But no, I completely agree that the great thing about, the institution as a whole is just how unique its culture is. And again, absolutely agree that, there are phenomenal institutions, all over the world, but I think Mayo is also in its own right a very unique kind of medical culture and kind of the structure of the practice, and that's been the historical tradition, and it has a very obviously storied historical tradition of great surgeons, great innovators, great clinicians throughout its history. And like I said, we're fortunate to be in a place where we have a touch point or an ongoing kind of role within that healthcare system overall.
I love the innovation side, and I want to talk about that a lot. But I think one of the things that really stood out for me at Mayo was kind of the operational excellence of it. Thinking about it's this enormous place, probably 10,000 patients there a day. I don't know the exact numbers, but it's they're all there for like the best experience in the world, and I think they're all feel like they're at this super bespoke place, and that is like just seems like an enormous feat to be able to accomplish that. Like everything that goes into the coordination and the collaboration, and obviously it's been honed over decades and decades. But being as a consultant and attending, like how does that? What's the behind the scenes collaboration and coordination to make that organize all of that chaos into like an incredible experience?
Yeah, it's extensive, and obviously we're just one aspect of it. But I think again, the unique thing about the institution is that it's a giant integrated group practice from its inception. And so it's maintained that level of integration of kind of coordinated care. That's truly where it excels. The ability to have not only infrastructure and resources to do things at an extremely high volume, but also to have rapid turnaround, but also, again, care coordinating. When I talk with colleagues and my brother about things, and the last questions about like how we would work something up or how this would be done, it's like, well, we just bring them in, we get a CT scan, a PET scan, they get their imaging done, they see us for consult same day, and then we're scheduling their, and they're like, and or even talking about other workups that would need to happen with other areas of subspecialty, whether surgical, medical, what have you. There's just not infrastructure many times built around doing that in such a truncated timetable, and that's just something I think that has been a long-standing tradition of the institution overall. And obviously and I tell patients a lot too that we're just one individual. Like the team, even just behind my own clinical practice, is massive. And so I try to reinforce the fact when patients are very thankful that, like, listen, I'm not just taking the curtain call here. There's a lot of people who are looking after you, and we're extremely fortunate to work with very phenomenal individuals and team members that literally make it happen beyond just who you meet as your kind of surgeon, quote unquote.
Yeah, a lot of things you mentioned are things I tried to borrow when I started my practice in 2010 from my experience at Mayo. Was some of the observations was probably shouldn't ever let space or support staff limit your ability to provide awesome care. It obviously costs a little bit, but that's it's well within the means of possible if you think a little bit unconventionally about how you're going to build out your organization. So for me, it was like I want plenty of space so people can feel comfortable. I don't have to be thinking about anything other than what's best for the patient in terms of when I need to turn over this OR or whatever. Like I just never wanted that to be the case. I wanted a recovery area for them to go to and stay as long as they needed to. And having RNs, which is a bit atypical in a lot of oral surgery practices, to me, I thought that was just allowed for a better experience. I'm pretty paranoid about everything that happens in the practice, so allowed me to feel a little bit more at ease, and that people were just we're in a well taken care of situation. And then staff, so not only be not limited by space, but not staff. And in our practices that we've tried to scale them across the country now, I think we have about 13 staff per doctor, and that was also something I really recognized there. Like people are in specific roles and they do what they do well, whether it's having a physician extender or all the different positions. I think like really Mayo has been exceptional at like leveraging the doctor's time to do what they do well, and not think about all of the other components of what makes a great patient experience, whether it's commercial or operational or cultural. But like when you're with the patient, you can be very focused on what you're doing. Is that accurate? Yeah,
absolutely. I mean, the ability to continue to put the needs of the patient first. I mean, that's the primary focus of the structure of how healthcare is delivered there. We're fortunate again to have team members that allow us to provide that focus, and to take the time with the patients that need the time, and to also have some infrastructure built around so we're not having to work for hours and hours to try to help to coordinate care, especially in a system that is highly efficient in coordinating care. But that's having the team and the support around you is absolutely critical. So I couldn't agree with that more.
As we have built Paradigm over the past 7 years, I wanted to really, culture I thought was so important at a couple of different levels, like organizationally across 32 states, how the doctors feel that they're part of something that's hopefully enabling them to really be the CEO of their practice, really have the tools and be empowered to sort of take their practice to levels they maybe wouldn't have otherwise. So for the the types of somewhat routine care that we provide, community oral and maxillofacial surgery, it feels like the healthcare is very local, and the brand is very important to be unique to that community, and that the practice have a culture similar to what I was able to experience at Mayo. It was kind of palpable to me. But how would you describe that culture?
Yeah, I think it's actually best summed up. I mean, we'll have patients that come up to us, and maybe it's at the tail end of a visit where they've received insert care X here for whatever condition they're coming in, and it happens unprompted frequently, where people say, listen, this was just an amazing experience, from going and getting our lab drawn, and to the person receiving them at the desk in like Hilton, where they're getting their lab draw, to everyone that they're interacting with in terms of the people on the first floor wearing the blue that help to direct them. It's just they can feel and believe that everyone is there trying to make their experience as good as possible, and that they truly care. And I feel like that is something that is truly something that Mayo has generally excelled at, is because when the focal point remains on the patient, whether you're the CEO all the way to the kind of entry level position, everybody is unified behind that common theme. And when it's a cultural intrinsic value of the institution, and it pervades every aspect of and every part of the personnel, because we truly believe that, I think it shows. And like I said, that's what contributes to the experience, because it's not just I think individuals just looking to try to again give them a white glove service. It's because people they're truly care, and I think that's why most of us who've had the fortune of training there, and who are those that are currently working there, they still feel that way.
How do you feel about building your individual team within the broader organization? Like for us, it would be one of our practices, say in Denver here, within the Paradigm umbrella, there's certainly uniqueness to the different doctors and the different practices. How do you think about what are your expectations for your team? What do you try to develop culture-wise for your practice within the broader organization?
Yeah, so I think one of the ways that, at least coming back on staff and and again, because I trained there, I obviously got to know the individuals in the ecosystem, but I still believe that the kind of most valuable asset of any business or healthcare institution is its personnel. I grew up for instance working in a restaurant, and there's so many parallels and correlates to I learned more. I tell residents even about kind of how to deliver healthcare and how to work as a team from that experience than I ever learned in any kind of formal professional training. And I think the personnel are the most critical. And so for me, coming back especially, was one, trying to develop the workflows around how we do things and why we do things, and again, keeping in mind that we want to have the best possible outcomes for patients, but also identifying the individuals that truly care. And so that's the OR team. That's my extender, Carrie Bacon. I'll throw her name on this here too as well. She's the one that keeps the wheels on the track for me, and she's somebody that truly cares about patients, and I'm very fortunate to have her. And also, like I said, my OR team, and there's always a bit of turnover in OR teams, but I've been very fortunate to have multiple individuals in my current team, notwithstanding two that truly care. I mean, just as an example, for these more complex cases that we do, we try to, again, make them as efficient as possible, because patients will do better. Regardless of the type of surgery, the shorter the surgery, they're going to do better. And so we're not rushing, but we're also not trying to extend out or bring in the opportunity for complications or issues to arise. And so to make that happen, my team will still, to this day, because there's a lot of moving parts to getting a free flap surgery going, they come in early just to meet our start time. And this is something that they made the conscious choice to do, and I'm forever grateful that they do that, because if every case that we do doesn't get started until 9:30, then we can't provide efficient surgery that gets them in and out. And so these are conscious choices that they have made to accommodate the practice and And like I said, they sacrifice for that. And we try to make a point to obviously thank them. And like, we're very fortunate to have those individuals who care enough to do that, right? It's finding those individuals, I think, first, and then trying to find a way to hang on to them as long as you possibly can.
Yeah, that's harder than ever today.
Yes.
Speaking of team, I think a unique part of your team is residents, and I want to talk about innovation for sure. And I know you lead innovation for the Department of Surgery at Mayo, which is an amazing responsibility and accolade. And super proud to have an oral and maxillofacial surgeon doing that at the pinnacle of surgery. But maybe start with residents a little bit as we move into innovation and technology, because I think that's a very, there's a lot of technological opportunities. And so I've never been on the leading side of residents. I've certainly been on the receiving side of being led as a resident. Mostly good, sometimes not super pleasant. But what's it like, working with residents? And
yeah, it's something that, like I said, I was fortunate to have, like amazing, like I said, great mentors, and like I said, being on both the kind of the receiving and kind of the giving in terms of the education side. I should also mention my wife Libby is a teacher, and so I sometimes will try to task her with giving me some insights as to how are ways, because we don't get any formal training on how to be educators, which is obviously something that I think there's probably more kind of conscious emphasis being placed on that, within kind of, academic medicine and surgery nowadays than there probably was historically. Same adage of see one, do one, teach one. That was kind of just the moniker of surgery, right? You kind of learn by seeing and then by doing, and then you teach the next one. And I think in this current day and age, the way in which not even just residents, but all of us kind of consume ongoing education and technology is very different than how it was when you were in training, when I was in training, and won't be the same in 10 years from now in training. And so with that kind of rapidly evolving environment, it's a matter of finding a way to try to continue to adapt and make our educational programs as optimal as possible. And our current program director, Jonathan Fillmore, has done an amazing job in terms of cultivating kind of electronic content that you and I would have killed for at the time when we were going through the residency, where he's essentially cultivated, reading lists and things that are immediately accessible for their training and available. In this current day and age, even like I said, having a compiled reading list is something that's in the process of going out of date, if not already out of date, in terms of how we consume information and knowledge in the current environment.
I think that's super cool how you talked about utilizing your wife to kind of learn as an educator and things, because I think almost everything I've done in life that's been successful has had education as a part of it in some way. And that's why I'm really excited about what we're building with Paradigm Innovation Institute and collaborating on to really be a part of changing or advancing education into the future. And I was meeting with an engineer the other day. I'm super interested in wearable devices. I'm not an engineer. I wish I was, but I was meeting with an engineer on that topic, and he was trying to commercialize something that he had developed. And he's like, I don't know anything about business. Like we're taught nothing about business when, in engineering or as we become professors. He's like, in fact, most of my job is educating, and we have no instruction on educating. So you can imagine what we know about business. So I was like, oh, that kind of makes sense. So I think that is interesting. Like, in surgical education, there's not a course on how to be a great teacher, really. And that's hopefully something that technology, can help augment and solve over time. And obviously it's been very effective. People have been taught well, but probably an opportunity we can think about a lot. What are your thoughts on?
Yeah, I think it's, we all, as time has evolved too, we all kind of understand and learn that people have different learning styles and different thresholds at which they need to have an exposure to something to feel comfortable, competent, and then hopefully attain at some point an expert level of skill. And it's about finding ways in which to level set everybody in a way that's meaningful, right? Like you may have someone who only needs to do 5 of insert this procedure, whereas somebody else may need to have an exposure of 20 to 30 to attain that same level. And so how can we utilize or leverage technology, and especially in an environment like surgery where, again, and I also try to emphasize this with the residents as well, that we have a responsibility to the patients to flatten that learning curve as much as possible. right? If you have a family member, or if it's your child, parent, and they're coming in for an operation, we intrinsically don't necessarily want somebody kind of coming in and quote unquote learning on that the first time, right? So we have a responsibility to our patients to, again, even with we're all the product of education. We all had to learn somewhere, but our own personal responsibility is to try to make that learning curve go from being as steep and having like the least amount of exposures, the least of potential. Because again, we talk about learning curves, it's really just a harm curve, right?
Yeah.
Like, when you have somebody that can do it at an expert level, how do we get that person who's trying to get to that point, get there as quickly as possible and as safely as possible? And so that's where I think technologies can be really intriguing in terms of whether it's, AR, VR, these other ways to expose people to, environments where they can hopefully get through some of that, especially the early phases of the learning curve, as quickly as possible to then be more proficient, more safe, provide more high quality surgical care earlier and faster.
Yeah, no, I think that's super interesting. And I think we think about some of these things very similarly as we were talking last night about how technology is changing the world. And I don't like to think conventionally. It's probably a flaw in a lot of ways, but I feel like the opportunities are sort of in the unconventional, sort of thinking about things from a first principles perspective and, throwing everything out the window and just, okay, if we want to accomplish this, if we knew nothing else about the world, like what would we do right now? And I loved how last night you had mentioned that you're like not the best speller, and that spell check is like a great technology. And should you have spent your time learning to spell more, or should you have like used spell check and learned a lot of other things? And I love that idea. It's like, yeah, if time were infinite and you had all the brain capacity storage ever, like, yeah, you'd probably be amazing at spelling and everything. But assuming you can fill that void, there's probably something more valuable to your patients than you spelling.
Right.
Even as we think about providing before residents or even the technical skills and cutting and all of these things, like the background information, the reading lists and things. And I think historically it's kind of like, okay, can you cite this article? Can you say what page this was on in this study? And I think that's probably changing a bit now. There were some articles I was interested in the other day, and it was a very long article, and I got like a quarter of the way through it, and I was like, I wonder if I just said like to ChatGPT, go summarize this article by Dr. Clayton Christensen about disruption in business, and just kind of an experiment for me. And so I stopped reading, I read the summary, and then I read the rest of the article, and I'm like, I'm not sure I needed to spend 45 minutes reading that article. I think I just got everything out of it. I probably might not look super well read if someone asked me a question about it, but I think I kind of know what I needed to know, and I might be able to read 3 or 4 articles in the amount of time that I read that one. I think those are the types of things that we'll probably see change, and it's probably more adopted by residents and just younger learners.
Right.
What do you think about those things?
As well, it should be. I mean, with the breadth of knowledge within medicine, healthcare, surgery being so extensive, we don't have the time to, like I said, as you mentioned, read word for word. If there are tools and ways in which we can still, again, at the end of the day, like if a day after you read that article, you probably still, in terms of what you retain, in terms of your actual long-term memory, even kind of intermediate level memory, probably more of what the synopsis was. And even just in the process of writing manuscripts and like that, you've experienced with that, and just what it takes to get something to that point, right? Yes, there's a lot of learning, but there's also a lot of time, right? And so like if we also could devote that time to expedite that process, to facilitate, but yet also end up still with high quality throughput, then yeah, we should try to leverage every kind of technology that we can to facilitate that. Because again, at the end of the day, those that will benefit will be our colleagues, ourselves, our patients. And so that's just the nature of how healthcare is and the science behind it, because it's so expansive. Gone are the days of somebody being kind of like an expert in anything general, right?
Yeah. Well, I'm hopeful that through PI2 and this collaboration, we can develop some of those types of things. And I know we're already working on the technology, and some of it is already in place. But creating digital twins in a variety of different ways. But creating the digital twin of Dr. Ettinger for different audiences. For the the dental student that would it might be interested in oral and maxillofacial surgery and head and neck surgery, or the resident that's decided I do want to do a head and neck fellowship, or the surgeon who's in a conventional practice in Dallas, Texas. Like what is it that they need to know so that maybe they don't have to go through 20 years of training like you, but at that point in their career, these are the things that in 20 minutes of listening to you hit on the high points for. These are the things that you need to learn. Like, sure, over time you should read these textbooks and everything, but here's what I can communicate to this resident today that will advance them on that path. Or, for me in Lincoln, Nebraska, when I'm seeing this head and neck patient that I know I'm probably not going to personally do the ablation and reconstruction of, like, what is it that I need to know and to be state of the art in my practice?
Like I said, there's all kinds of opportunity. And again, in practicing in an environment like Mayo, where I think if anything, the longer you're there, you begin to realize like how your kind of niche area that you live in is just a very limited subset of what it takes to care for an individual. And so to that point of like, if I'm referring somebody to something else that we're diagnosing, and I also want to know what is like the minimum threshold necessary to get them onto the care that they need, which is ultimately not necessarily going to be, for instance, with me, if it's a patient with a newly diagnosed lymphoma that we biopsy with a head and neck disease site. I mean, there are things that we need to have a minimum threshold for to understand where they need to go and how to process them in a way that gets them their rapid care. The use of digital twins in all kinds of different environments is a very kind of intriguing, whether it's from like a personnel kind of replacement standpoint or whether it's something that we use for actual, like I said, patient-specific, individualized surgical care in medicine. I mean, there's unending opportunities for that specific application, and that's like an entire podcast in and of itself to talk about. But like I said, there's all kinds of new ways in which, you could have somebody that maybe at some point we could have, like I said, somebody who's a phenomenal educator, and how do we encapsulate that and preserve that for future generations? Or we talked last night a little bit about how to preserve like a surgical expert in a given thing. And once that individual retires, like how do you keep that going in perpetuity? Or is it, we'd have to wait like another 10 years for somebody else to come along that has that capability? So there's all kinds of really unique opportunities in which we can leverage existing evolving technologies to try to better preserve, whether it's expertise or education. I mean, there's so many different possibilities in which that technology can be used.
Yeah, it struck me last night when we were talking, I hadn't really thought about it, but like preserving educators, their experience, recreating them, because I think, the holy grail would be to just have, sentient AI that can just develop perfection. Like this is how this is the protocol this person should be treated by. Maybe it operates a robot that can do the perfect surgery, but we're probably not in our lifetimes. Well, maybe, but it might be a while before we see that. But like, can we preserve things? And the example I think we were talking about last night was like Dr. Nagorny, probably like a once in a generation or multi-generation hepatobiliary surgeon. Maybe we can't create perfect, but that might be as close to perfect as there is today or was. And it's like, it's unfortunate in the past that like knowledge sort of disappears with these people. So is there a way to, recreate you in 10 years or 20 years so that like capture your state of the art? Because, if we had 100 of you doing head and neck surgery, that'd certainly be more valuable for humanity.
Sure. Well, I mean, we have, the standard historical model within medicine and surgery is you do your residency, but then if you're going on to, for instance, like specialty training, it was very like lineage dominated, right? If you think about like fellowships and how fellowship, it's like you can talk about your fellowship, but then the next follow-up question is, you'd say, I went to this fellowship, insert fellowship director that you worked with, right? So it's a way of, that's been the historical methodology of how we kind of maintain, a style, a skill set to the next generation, is by that direct transfer of knowledge, right, from one individual to another. But also, by the way, how great would it be to preserve that individual, like I said, in perpetuity in some fashion or another, right?
Or
so
build
that it can
off
be shared.
of it.
Or correct, or build off of it, yeah.
I know you guys are doing some things with virtual ORs or ORs that capture all of the movements and or at least head in that way. Do you think it will be possible where just through imaging, videos, scanning, that like every movement will be documented for hundreds of surgeons over many years, how people move in the OR, why did you decide to ligate this artery versus not, and sort of like codify your judgment? Or is that something you see?
It's something that I think is certainly coming along. I think there's very specific surgical applications where that kind of style of like I said, kind of judgment codification via review of video and tracking is, like I said, relative to like laparoscopic procedures, robotic procedures, where there's inherently always a camera, a field, and you can literally drive down into the minutia of how things are done. And there's even new companies developing, you get your essentially surgeon-based report card of how you do in comparison to others that are a part of this product ecosystem that are also having their videos recorded. You actually get ratings, and it allows you to give actual feedback, for instance, to providers and saying, well, look at how this person does with this, and where you can actually improve, which is something that we truly kind of lack in surgery in general, right? We get trained, and then we're in practice, and then we, like Dr. Fernandez used to always talk about, we don't have coaches anymore, right? We, even the highest level athlete, Tom Brady still had Bill Belichick, right? I mean, so these are not individuals that can do what he does, but he's still functioning in a coach role for that individual. And so whether we become kind of our own coaches or whether it's kind of a community-based coaching system via instrument tracking, via video, I think open surgeries, it's a little bit more challenging. Although that being said, our group has recently moved towards making a point of doing more video recording of open surgery so that we can not only use it for education, but also, like I said, it can at some point potentially be utilized to hopefully, like you said, codify what we do, how we do.
Yeah, I have a sense there's probably so many things that play into an outcome that you don't probably even consciously know. Like, it's just a matter of judgment that for some reason, you make these decisions and they may not even seem critical, but this surgeon gets a better outcome than that surgeon. And maybe it's not even a matter of they had a better aligned fracture, or they're, things that you would conventionally think equal perfection. There's probably so many factors that weigh into this, like, oh, they stayed under anesthesia 15 minutes longer, and turns out that had an impact. So maybe the alignment didn't look as good, but maybe there was something for that patient, or someone contaminated something in the OR that you didn't. So I'm super fascinated in like the variables that you might not think of.
Yeah,
conventionally.
Right, and I think it's ultimately going to be a cumulative effect too, right? I mean, I try to make it a very intentional point to try to control the things that we can control, because there's so many things in patients that we can't. And so to try to manage those things to the best degree that we can, we owe that to them to do that, right? To ensure that they have the best possible outcome with the things within our sphere of control, because so much of that lies outside of it.
Yeah, I couldn't agree more. How do you think about robotics for training and just for enhanced surgical ability? Like, where do you think that's headed?
We're kind of, I think, at a very interesting time point in which, there are existing robotic systems, but they're currently being developed, and also different robots for different applications and different areas of surgical subspecialty. And I think of, robotics and even new kind of like more amorphous or kind of abstract tools, like I said, use of AI deployment for various points of healthcare delivery. These are all tools, right? It's a matter of for me personally, like, I don't use a scalpel, I use a cautery, right? So that's just the tool that then replaces the tool that was used before. But it still comes down to a matter of how do we leverage and utilize that tool to the best extent possible, right? I think that, I know, even talking to, I have a very close friend and colleague who's also in the AI space, but is in orthopedic hip and knee, and he was talking about how he feels more comfortable working with trainees, meaning when there's a robot that's there kind of providing that kind of secondary we call it layer of safety, where or if it's a complex revision case, that he just feels more comfortable knowing that that's a robotic assisted case versus essentially a freehand osteotomy being done, and so that affords him the opportunity also, and again, in an educational standpoint, it allows you to level set and ensure, further degrees of potential safety, right? And like I said, even just the opportunity to review video, if it's a robotic, video recording, you can go back and relook at how you did and what you did, even just on a personal level. So these are all, like I said, multiple tools, and even in the robotic setting, there's lots of new robots currently being developed. So I think we're going to see a lot of evolution of that over the next 5 to 10 years in terms of, different robotics companies starting to find their way into clinical application and into market. And
what do you think about VR?
Yeah, so I think VR, and actually I have my own kind of interest with regard to, like I said, mostly augmented reality or essentially AR guided surgery specifically. I think VR is a great tool for pre-OR, preclinical type of education or kind of knowledge sharing, especially in like amongst residents. But to have, like I said, a functional heads-up display during surgery for insert your parameters, whether it's interceptive preemptive knowledge on specific anatomy that's coming your way as you're trying to do a tumor resection, because I can actually see ghosted in my view here. This is a tumor with this critical structure adjacent, or the carotid coming through right here, with planes being distorted by tumor inflammation, and to be able to see that before you get there, like that would ultimately, even again just with further layers of safety for trainees, to have something like that, who are lacking that experience, to say, no, this is coming your way, so you need to be aware, so that you can. Now, we're not there yet, and some of the work that we're trying to do and actively working with companies is to try to find ways to bring that into the OR for common clinical use applications, right? It's still something that's very kind of new and novel, but it's something that I would ultimately hope, just like when you have your heads-up display driving down the road in your car nowadays, it's like to have like a heads-up display with certain parameters or certain critical anatomy to augment the surgeon, such that whatever we're using for loops now can be like augmented loops in the future, right? Like that's a long way off yet, but that would be something where we may look back on that and think, how do we ever do things without this?
Yeah, I'm sure. What are the challenges in terms of like fiducial markers, hard tissue versus soft tissue haptics? And
yeah, and again, we come from a specialty that was very ingrained intrinsically within hard tissue surgery, so we're actually super comfortable with fiducialing, with co-registering, hard tissue structures, and whether that comes from orthodontic surgery and how we originally did natural head positions to how we actually do things in the OR. But one of the problems is, especially with the type of surgery that we do, and even in other areas of specialty, is dynamic surgical fields. We have nav, we have other technology that allows us to co-register, but it's typically going to be in applications where you have a static field, where somebody's doing something in the spine, that table's not moving, the patient's not moving, or somebody's doing sinus surgery where the head is not moving up and down, or we're doing something in neuro with stereotactic guidance that again, head's in a halo with pinions and it's not going anywhere. But I don't have the luxury personally of working in a static field. Our fields are dynamic, there's soft tissue, there's dissection planes and things that are going to change. And the trouble is, how do we continue to, in real time, continue to co-register information and data that allows us to see that interceptive knowledge of structure, of critical aspects of the procedure in real time. Oh, by the way, different than how the patient came into the OR and just laid supine on the table. That's the challenge right now.
So there'll be far less certainty as the model or the image that it'll be based on prediction sort of in soft tissue?
Well, there just needs to be some degree of tracking, right? Like you can fiducial instruments and that can help you to track, but there's also motion tracking that is existent within technology right now that allows you to, as an example, bring a hand into field, and that gives you an option of a menu on your hands in your AR guided view, right? So that's not something, my hand is not fiducial, for instance, but there's motion tracking, and it's continuing to develop that technology or finding other ways to co-register structures outside of hard tissue points, because as soon as you shift those, there has to be something that happens dynamically with the tracking as well, and that's kind of the holy grail to then get guidance into into soft tissue surgery, where it's not just, again, fixated structures that don't change over the course of an operation.
And then how about the haptics as it continues to improve? How do you think that will affect things?
Yeah, so some of that will come down to, like, again, the AR application, but having, for instance, more so in robotics, is having that haptic feedback, to see or to know, what's going on. That's something that's under active development as well. Argue too that many times, like, haptics, in talking with certain robotics companies, is that it's something that you can learn around and kind of work around, in the sense that you don't always need to have haptic feedback to know that, for instance, as an example, during micro, that a vessel's being pulled too hard. You can see that that's already happening, and that's maybe with working with the trainee, stop pulling that hard, that's going to be an issue, kind of a thing.
Yeah.
Like, I'm not getting the haptic feedback for that, but you can see it coming, and so that is something that, again, is a challenge for sure. But also, like I said, depending on the application of the technology, isn't always something that it would be phenomenal to have, but isn't necessarily always needed, per se.
I know with your role as leading innovations, you have a lot of things going on. What are the areas that you're particularly interested in?
I have a number of areas of kind of personal interest, and like I said, the role within the Department of Surgery is to kind of help to oversee and navigate. And it's actually a partnered role with Dr. Cornelius Thiels, who's another hepatobiliary surgeon that has a lot of interest in data analytics and AI. And so it's actually a role that was originally started with Janine Reisenauer, who's a thoracic surgeon, and the kind of growth that we've seen in that arena has continued to expand year after year after year, such that they even had to expand just the leadership just to provide the additional bandwidth to deal with all the different opportunities and to help navigate our own Department of Surgery ecosystem for companies that are looking to work with or partner with to help to develop the next lines of technology that extends from devices to biopharma to data and analytics. I mean, the term innovation gets thrown around a lot, but it's an extensive area that has multiple points of insertion, again, into the healthcare system. And it's just a question of how do we help not only our own providers and our own surgeons to find things that they're passionate about and can do to shape the future of healthcare, but how do we also help connecting those individuals to the right individuals externally as well. And so Mayo has done, especially within the Department of Surgery, a very targeted kind of switch to try to help to facilitate that as much as possible, whereas I think historically that was maybe not something that was as focused on, and innovation has effectively become kind of our unofficial fourth shield outside of education, research, and clinical practice.
Yeah, I think it's your role in innovation that sort of got us connected on this partnership and PI2 that I think is going to be really exciting, the things that we can do in terms of innovation and education, bringing those things together. The areas that I'm really interested in are sort of large, big data and how that can answer questions for us and things that that wouldn't have been obvious otherwise. And I'm certainly no data scientist, but I get to hang around them a lot and have learned a few things. So what areas in big data are you interested in terms of questions to answer and having a network of hundreds of surgeons and locations and thousands of dentists to capture data from?
Yeah, I think there's multiple points. I think, one of the things that for me personally is obviously would be kind of the holy grail of use of, like I said, big data or large scale data, is to continue to improve, like I said, individualized medicine and treatment decision making based on patient specific individual risk factors, right? I mean, the idea of, like I said, the digital twin of somebody that's based on a model that's vetted within historical, highly curated data that's of high quality, that allows real-time treatment decisions to be made, different than how we stage patients currently in oncology applications, right? Staging is not necessarily reflective of that individual patient's risk, but it could be in the future if you can develop models such that we can import or utilize patients' own specific risk factors, their biologic parameters, demographic parameters to again continue to tailor their oncologic treatment to what they actually need, not what a population would get looking at it in a retrospective fashion. The interesting thing with Paradigm, and like I said, some of the work that Steve Weimer's done with like the outpatient anesthesia safety is you have a super unique opportunity to leverage through the network of the practice access to readily available but also highly refined data sets that, like I said, we don't in the academic world have access to that level of clinical volume, because you have a common networked set of practices. And so to do these large scale studies that require significant power to identify what are, albeit very, very limited, rare outcomes, but equally as important outcomes to identify and find ways to prevent. And so the ability to leverage that, the initial study within Mayo, and then Steve Weimer was able to, in 17,000 patients, and he was then able to expand that out to 70,000 patients within Paradigm's network, and to be able to do that is commendable, because that's the type of thing that we don't have the ability to do even in single center studies, with coordination with data quality in terms of having a homogenized data set that's readily accessible, available, and that's a very unique opportunity and strength of what you've developed.
I think that's where the collaboration is like so powerful, because there's things that we have that are very critical to doing those, but to have the expertise and the content and all of the sophistication that Mayo has that has taken 100 years to develop, we could never really probably optimize what we have without that kind of partnership. But I think the things that we do have that are unique is, while we're not super huge and sophisticated, we are like very focused and we're distributed, and that sort of has snowballed and scaled and like grows quickly. And for every surgeon, there's 50 dentists that it reaches. And so you start to get this network effect. And I think with big data, at least in sort of healthcare and business, a lot of the research, or a lot of the work that would traditionally go into research, is basically the decision points that you make along the way. Like the decision that you make to, okay, we are going to develop a data ecosystem, and we are going to develop a team, and the studies go like very fast, but like all the infrastructure that you had to put in place, transitioning hundreds of surgeons to create the change management, develop the team to implement that software, develop the standard operating procedures so that the data that's going in is not garbage, that we're all registering patients the same way, we're putting the same markers, and being forward thinking, like what might we want to do in the future with this, so that we make sure that we maybe do something, a little extra work today that might not be obvious, but it'll allow us to answer some questions with data in the future. And that's where I think we've been really strong in thinking a bit into the future with our company, or with the way we were operating things. And I think the opportunities to do studies, I mean, I almost feel guilty when we do some of these studies now, because it's like so fast. Suddenly you have 64,000 patients, over a 1-year time period. And then it's like, well, okay, now then you can start kind of asking questions, because we know this person was seen, they were in the operating room for this many minutes, they got this many milligrams of Toradol and this many milligrams of midazolam, and this many cc's of bone was used, and they live on this street, and this is the kind of job they do. They were born when there was a full moon, or you can just kind of mine this stuff indefinitely. And that's what I think is like so cool, to drawing conclusions that you might not, or gain insights that you couldn't have otherwise. And we recently did this paper that's underway on implants, gathered 28,000 patients in I think about a year, but the decision to study the data was like a matter of days. Then it becomes challenging to then put it through algorithms to identify patient features that are predictive of this or that. Those types of things are really, really interesting to me. As you think about like that network and the data that we have access to, and we're not doing thousands of tumor resections, so we maybe don't have biomarkers or things that would be relevant, but what types of studies or questions would you think could be asked?
Well, I think that you guys are in a very unique opportunity. What are kind of standard of care kind of research questions that you could actually derive answers for, right? Like I said, the types of things that we can't do in studies that are underpowered to look at very limited outcomes. And if you can, like I said, generate 60,000 patients at the click of a button to actually look at and again and I think that's one of the things that's been largely lacking unfortunately within dentistry oral health, but also healthcare overall, is the ability to have broad scale networks of like I said, data as it's coming in being refined, being searchable, being queryable, because there's always inherently going to be this inverse relationship between the size of the data and the quality of the data, right? Like you can have an extremely large data set with a lot of noise or a lot of missing parameters or variables that then needs to be gone through and cleaned and refined before it can help you to generate a high quality predictive model, versus having a very highly curated limited data set that's maybe done by a surgeon who has the clinical context of understanding the nuance of what that data is. And I have some my own very interesting thoughts as to whether, like, in terms of training, which of those two would be better suited to deriving model, or maybe they have similarities or equipoise. But I think with respect to kind of the scope of the practice that you guys are doing day in and day out, and like I said, even as it pertains to whether it's implant success outcomes, we all know the things that we're quoting from limited evidence, and you guys have an opportunity to provide high level evidence potentially with adequate power to answer some very basic to some very potentially advanced questions with regard to what you do day in and day out. And again, as somebody who's an academician and I hear these numbers of patient cohorts that you can generate within a matter of a day and have actual high quality evidence that you don't have to go through in mind charts to get, I'm like sitting over here salivating thinking about like what that would be like if we could have something like that immediately accessible at our fingertips, which there is Mayo has its own broad scale data platform. It's actually called Mayo Clinic platform that has data that's queryable and a newer service and availability within the clinic at large, but it's a matter of getting it and using it in the way, and like I said, there's invariably going to still have to be some degree of filtering and populating that will even go on with that. But it's an enviable position when I think about the type of stuff that you guys have the opportunity to look at.
Well, I'm super excited to have your help in that and leadership. I think we just have tremendous opportunities in dentistry. There's some parts of dentistry that are like incredibly advanced, scanning, digital workflows, all those things where they really even lead medicine in some ways. But there's many ways where it's just somewhat antiquated. I think maybe things have changed, but I don't feel like I was in dental school that long ago. And, I remember learning about GV Black principles, as if they were like very important things. I mean,
right.
Historically, yes, but,
right.
So I think we're sort of in a time where I think we can really contribute to the advancement of dentistry and really, I think, oral health. And I'd love for dentistry to be thought of more as oral health than dentistry, because I think, especially in oral surgery, we sort of, in the hospital setting, sometimes, are put down a bit as, just dentistry, which I completely disagree with. But I think it's like, our responsibility as dentists and surgeons and physicians to sort of elevate that, because I think dentistry is, extremely complex and challenging, and it's crazy that people talk about oral systemic links as if the mouth requires some link to the rest of the body. Like, oh, I'm going to show you this really cool trick that the mouth is actually connected to. It's like, it's a term that should go without say, really. But how do you think about oral systemic health? You obviously experience it at its extreme.
Definitely, that's one of the exciting things that I said about kind of what's gone on with how your practice and companies developed over time, is the ability to unify providers across a broad scale, right? And that's something that I think will help to continue to elucidate connections and relationships between again, the oral cavity, the microbiome that exists there, just like things that are happening with omic data in GI. And until we're unified, until we look at things from a broader perspective and again can relate that back to the body, you're always just kind of thought of as like it truly is like a black box in medicine to an extent. I even remember, and you maybe relate to this as well, even in medical school, they ask you to give as the OMS residents in the class, they ask you to give like a 15-minute lunch presentation about dentistry, like as if you can distill down the entire training and scope of that into a 15 15-minute talk. It's a little bit, I mean, it's borderline insulting, but but it's like, but that's the thing, is that there's just not, and that is the extent to which there's any formal education given on that area. And I think we talked about this a little bit too. It's like, for whatever reason, the mouth and your eyes are not considered part of your body, and everything else is. And that's an unfortunate consequence of how the two specialties have diverged to an extent over time. But I definitely think, like I said, with practice unification, with, connection of providers, with an institute focusing on, raising the level across the board, there's more opportunity to, like I said, leverage the numbers, leverage the providers, and to try to do some really interesting work.
I think that the payer structure and things has definitely contributed to the eyes and the mouth being sort of separate from the rest of the body. But I don't know of any sort of collaboration or organization that sort of tried to approach the opportunity of really establishing oral health and wellness associated with the whole systemic situation. So I think that kind of underpins like what's, I think, really critical to what we're building in Paradigm Innovation Institute is how can we be a part of really be the thought leaders in all things associated with oral health and how it affects the rest of the body. And I think we'll probably have to, I mean, certainly we're already, we've invested in data science and technologists and, all kinds of areas that I never could have imagined, 20 years ago in dental school or even 10 years ago in starting a practice. But I think we're probably going to have to get outside of our comfort zone a little bit in terms of the types of people that we bring in if we really want to push the envelope forward. I was reading an article on business disruption in the Harvard Business Review the other day, and they were talking about that companies or organizations that think about their customer and and developing new products or new services that are synergistic to the customer, or the patient, as it would be in our case, is really the companies that really thrive. The ones that sort of try to develop synergies that they can capture from a business perspective are very short-lived. But to do something like tremendous, it's if you can develop synergies and accrue those to the customer rather than just, okay, now we can make a little more money. And I think in the long run, you develop a super sustainable company that's probably very profitable and just has brand unlike others. So that's what I really want to focus on is like our customers are our patients. So we're in a very unique situation as we think about developing synergy. Those are thoughts that are really important to me, and I think we'll probably need to start to invest in different types of talents that know these parts of science and technology beyond what we do in our day-to-day practice. But that's what I think is really exciting, is being able to step outside the box. And you strike me as someone who definitely likes to kind of step outside the box and discover what's possible.
Yeah, well, and I think you're thinking about it the right way, right? I mean, the thought of, I'm sure, was you were building this over time when you're in your initial office to then think that someday you'd be hiring data scientists to look at, it's just, or programmers and that are going to look at machine learning and AI algorithms. Is like that was probably nowhere on your radar at the time, but that's how it's evolved. And obviously the growth and success of the company has enabled that to occur, because if you're just trying to make it day to day, you don't have the mental fortitude or bandwidth to try to do these bigger questions. And that's, like I said, that's a commendable thing, to get to a point where you can think largely about this and how do we actually try to change the oral health environment, at large, right? Like what do we need to do? And the things that you're actively doing and have done to this point speak to that. And that's, again, something that I think is very unique in the kind of business / healthcare ecosystem that you're in. And like I said, I think there's a lot of potential, models to be drawn from that are applicable and scalable to other areas within surgery, medicine, healthcare.
Well, I think what we're creating is, a physical platform where people can come and learn, and, a think tank, innovate, do research, present, teach others, but then also, a virtual platform like we were talking about. People just learn a bit different today, and we need to be able to develop, very high yield content that can be delivered quickly. So I think, bringing great minds together, bringing people that have a shared mindset is so important. There was another article I often reference in HBR, but it was talking about the 5 intangibles, I think, the 5 attributes to create intangible value, something like that. But it was the areas that I've naturally been obsessed about are talent, speed, and innovation. Those were the kind of numbers 1, 2, and 3. But I've kind of come to realize that it was 4 and 5, which was accountability and shared mindset that really allow people to do incredible things. Like the things we're talking about, none of us could have the knowledge to do all of these things. But if PI2 can manage to bring together people like you and other brilliant clinicians and scientists and dentists around the world to innovate in our focused area of dentistry and in oral surgery, and I think we can do something really special. So I think that's what's going to determine our success, is can we develop a common vision and inspire people to join that. What are your ideas or thoughts around how we do that?
Well, I think like I said, most anything is going to begin with a relationship, and we have obviously a connection through kind of similar backgrounds in training, and like you mentioned, it's kind of that group mentality. Initially, we're all kind of pushing towards common goal, and like I said, we're aligned in the right way by kind of basic value systems, which I think is kind of the certainly the first part. And I'd actually be very excited to see kind of organically what this continues to grow, and something found in education, but I think there's endless opportunities in which this can evolve over time to unforeseen areas, just like we were talking about before. Like the things you're thinking about now or working on now was probably not even on your radar, call it 5 to 6 years ago. And so I'd be very curious and excited to see what those, the next 5 to 6 years would bring in terms of the things within like an oral health setting we're thinking about then or working on then. But I think having that common ground, common background, and a relationship upon which to build is going to be your most critical step.
Well, Kyle, obviously the things we talked about today don't happen in silos, and it's because of people like you that are willing to push boundaries, collaborate deeply, and be interested in building something bigger than themselves. So I'm excited about the work we're doing, but I'm even more excited about the people that we're going to be doing this work with. So I really thank you for joining us today.
Yeah, appreciate it. Thank you for the time. I think it was a great discussion, and again, looking forward to build on that in the future.
Well, thank you. And thank you everyone for watching. I look forward to seeing you in the future.